fun, but this doesn't require you to scrutinize any strips, so that's probably a good thing. Give you a break. Okay, we're going to talk about poisoning and overdoses. I don't have any conflicts of interest, and I will try to point out some of the off-label uses. There's not a lot of evidence-based medicine in toxicology because of the wide range of drugs, and there's really not a lot of clinical trials. So most of our anecdotes and some of our interventions are really not approved through the FDA. So when we're talking about managing a patient who might have a drug overdose, there's several aspects that we need to at least kind of progress through. Obviously, first, resuscitation and stabilization. We want to know what the diagnosis is. We may or may not be able to get rid of some of the toxin. But a lot of what we're going to concentrate on today is really about the antidotes and the specific interventions. And, of course, there's a lot of supportive care. In fact, that's probably the majority of the type of care that we give to these individuals. For resuscitation and stabilization, it's the ABCs that apply, but the D is also important here, and it's a D for the depressed level of consciousness. And this has often been called a coma cocktail, which is the use of naloxone, thiamine, and D50. What you'll find nowadays is that there's more response to naloxone if you're using the appropriate dose because of the narcotic problem that we're having in this country, and we'll talk more about that a little bit later. The diagnosis depends a lot on the history and a little bit on our laboratory testing, but the history is often not reliable. You can ask the patient what they took or a family member and the quantity, but lo and behold, about 50% of the time it is not accurate. That's not surprising. You do want to know the time of ingestion. Did they take it 30 minutes ago or did they take it 5 hours ago? Because if they took it 5 hours ago and they're alert-oriented, then probably you're not going to have to worry about too much toxicity. We do have sustained-release drugs which may improve patient compliance. They are terrible when it comes to toxicology because of the ongoing absorption. So you would like to know what type of formulation of a drug that you're dealing with. Acute ingestions are also a little bit different than some of the chronic ingestions, and sometimes you also have acute on top of chronic. So kind of putting that into perspective may help anticipate complications. Now, you're going to do a good physical exam, but in reality, what you want to concentrate on are your vital signs and your neurologic exam, because what you will find are some patterns, things that tend to increase the blood pressure, increase the pulse and the temperature, fall into categories of the amphetamines, cocaine, anticholinergics, and other sympathomimetic drugs, while those that decrease blood pressure, heart rate, fall into narcotics, the sedative hypnotics, and some of the antihypertensive drugs. So often you don't need or you won't ever be able to identify a specific drug, but you can classify them into what's called a toxidrome, which is basically a clinical syndrome of poisoning. Now, the most common ones are really all of these, except cholinergic is not very common in the U.S., and we'll talk a little bit about that later as well. Now, what about getting the drug out of the gastrointestinal tract? Well, there are several things that we use, but Ipecac is off the list. You don't need to worry about that anymore. Cathartics never had any benefit. They were just used because of the theoretical benefit of getting drugs through the GI tract faster, but it really hasn't panned out, so you don't need to use a cathartic. Gastric lavage, there's no definite indications, and there's not any good evidence of benefit, and there are potential very dire consequences or complications associated with that. So we're doing much less gastric lavage in our patients. Whole bowel irrigation, this is where you give a polyethylene glycol solution till what goes in looks exactly the same when it's coming out. And again, the theory here is that you're moving drug through the GI tract. There again are no indications. There's no clinical evidence of benefit. It's been suggested for sustained-release drugs or illicit drug packets, but that, again, has not been proven to benefit the patients. So we're left with activated charcoal as probably the better of our methodologies of gastrointestinal decontamination. The dose for activated charcoal is 1 gram per kilogram, but one of the limiting factors is that you have to give this early, within 1 to 2 hours of ingestion, for the best effect. Now, you also may need to administer this through a nasogastric tube because a lot of people don't like to drink black stuff. And often they're not willing to, no matter what color it is. So a nasogastric tube may have to be inserted. Now, the limitation of charcoal, particularly in the adult setting, is that it does not absorb lithium, which if you're dealing with a population that with psychiatric issues may be a problem. In pediatrics, it does not absorb iron. So our current recommendations are in someone who's critically ill, life-threatening ingestion or potentially life-threatening, and you don't know for sure the time of ingestion, then charcoal would be reasonable. You may consider lavage if the ingestion is within 1 hour, but you don't have to do it. The majority of the patients will fall into the other two categories. They're either asymptomatic with mild or moderate poisonings or they're benign ingestions, and most of the time this is observation. If they're a moderate type of poisoning, you might consider charcoal, again, if it's early enough following ingestion. Now, the other possibility of getting rid of toxins is to use the normal hepatic and renal functions to get rid of toxins. And in the past, we often used multiple doses of charcoal based on the assumption that drugs had an intrahepatic circulation and we were grabbing onto the drug or metabolite again when it entered into the GI tract. Well, our kind of love affair with multiple doses of charcoal has waned too, and currently the only drugs where it might be of benefit, barbiturates, which we don't see, theophylline, not used very often, so maybe carbamazepine, never seen a dapsone or a quinine overdose, so that would be another possibility. Forced diuresis, you can get that off your list. You may increase the urine output, but you don't really enhance the excretion of drugs enough to consider this a viable option. Alkaline diuresis does work to enhance excretion of barbiturates, which we don't see, but it does help with salicylates, which are not that common. And here you want a pH on the urine of at least 7. Hemodialysis and hemoperfusion are reserved for those ingestions that are life-threatening or potentially life-threatening, and these have to be small molecular weight, water-soluble. They can't be highly protein-bound in order to get them out of the circulation. Now, continuous techniques, primarily veno-venous techniques, have been described, but the experience is much less rich. So I would say I would steer away from those unless you absolutely had to use it in a patient who had hemodynamic instability. Let's talk about some of the drugs, but before we do, I always like to remind you what kills people, because theoretically we'd like to prevent those deaths if possible. And the list, they just redid some of their classifications a couple of years ago. But at the top are sedative hypnotics and antipsychotics, but right below that is acetaminophen alone or in combination with other drugs. Opioids, these are really the top 3 that you're going to need to be able to intervene on. Antidepressants, again, has been going down the list because we have safer antidepressants. Some of these others are not surprising: stimulants and street drugs, alcohol, and even cardiovascular drugs, because they're found in the home and people will overdose on what they have available to them. Now, let's start with acetaminophen, because this is one overdose you never want to miss, because we have good treatment that can prevent significant toxicity or even progression to fulminant hepatic failure. Always think about this as a co-ingestant, because it's present in over 200 over-the-counter and prescription drugs. You can give charcoal. It does absorb acetaminophen if it's early after ingestion. You, of course, are going to assess the level of acetaminophen in the blood. It has to be at least 4 hours after ingestion. In your slide set, you have the Rumac-Matthew nomogram. It has nothing between 0 and 4 hours. So don't get a level unless it's after 4 hours after ingestion. The limitation of the Rumac-Matthew nomogram is that it is only for single acute ingestions. It does not work for chronic ingestions. It does not work for repetitive ingestions over time. And it's now been estimated in some emergency departments about 50% of the patients are multiple ingestions or chronic ingesters over time. So there are limitations to its use. There is an extended release form of acetaminophen. So if your first level happened to be non-toxic in that instance, you have to get a repeat one, because the second level may now go into the toxic zone. This is just a reminder of some of the concentrations of acetaminophen. It's been said that most of the people who overdose do so inadvertently because they don't recognize that the medications they're taking contain acetaminophen. In other words, they might take Vicodin and also take Tylenol. and they can easily get up to the recommended daily dose of 4 grams. The FDA is actually looking at this very closely, and there's been considerable discussion about decreasing the total daily dose to like 3.25 grams and also making 1 gram doses of acetaminophen as a prescription drug. So again, keep in mind that your patients may be taking more than they should of acetaminophen. Well, you know the antidote. It's either oral or IV N-acetylcysteine. There's a couple of slides in your handouts with the exact dosing. But the key point here is to get the drug in, one way or the other, within the first 8 hours following a significant ingestion. So if you don't have your level back, but it's a potentially toxic ingestion, you start your treatment, you can always stop when your level comes back. If you start within 8 hours, the chance of hepatic toxicity is almost 0. Now, we give N-acetylcysteine as far out as 24 hours, and we certainly give it to those who have fulminant hepatic failure, presumably due to acetaminophen. What do you do about those chronic ingesters, however, those who take multiple doses over time? There's no fixed recommendations, but these are suggested ways to approach that. First of all, look at their transaminases in this case. If they're greater than 50, go ahead and give a full course of treatment. If they have an acetaminophen level greater than 10, go ahead and treat. And again, obviously with fulminant hepatic failure, you want to go ahead and give a full course of treatment. Okay, the alcohol is always a favorite for board exam questions. You have a patient with a history of ingesting ethylene glycol 24 hours before coming to the ICU. He's comatose and intubated. The anion gap is 22. There's no osmolar gap. It's normal. The ethanol level is 0, and you have a blood gas with a pH of 7.09. PC2 is 30. PO2 is okay. So which one of the following interventions is most likely to benefit the patient? Ethanol infusion, ethanol plus hemodialysis, hemodialysis, fomepizole and dialysis, or thiamine and folinic acid. This is silent question. No music. Okay, well, actually, I would suggest the correct answer is C. Now, again, I've changed the order a little bit in your slides. One of the things you have to know a little bit about metabolism here. I'm sorry about that. But the alcohols, first of all alcohols will give you an osmolar gap. So this patient had no osmolar gap. So there was no alcohol present at that time. And the reason is, in this particular patient, he came in 24 hours later. So all of the alcohol had been metabolized to an acid. So he has an anion gap and no osmolar gap. Now, the reason we said the ethanol level was 0 is because all of these are metabolized through alcohol dehydrogenase. And ethanol is preferred for that enzyme. So you can tie up the enzyme and still have another alcohol there. But again, there was no osmolar gap. So both ethylene glycol and methanol will give you this kind of presentation. Depending on your area, you may have one or the other. Usually in Houston, it's ethylene glycol. They present the same. They're inebriated, they have cardiopulmonary symptoms, they can have renal symptoms, and the classic findings are not usually present. As we just illustrated, you can have an anion gap acidosis and no osmolar gap. Let's say in the rare instance that someone comes in right after drinking the alcohol, they might have an osmolar gap, but they might not yet have metabolized them to acid, so they might have a normal anion gap. Now, the other instance where this becomes a problem is if they have ethanol on board, they may have an osmolar gap and no acids because the enzyme hasn't yet had an opportunity to metabolize that lethal alcohol because it's tied up with ethanol. So you have to look at your ethanol level in these people. Now, we don't usually distinguish between these two because the management's the same, but oxalate crystals are a clue to ethylene glycol. They're transient, present in only about a third. Visual disturbances, if they give you that clue, is a suggestion that you're dealing with methanol ingestion. So understanding the metabolism also helps you understand our interventions. First of all, we can inhibit alcohol metabolism by tying up the enzyme, the alcohol dehydrogenase. The gold standard has been to use ethanol, which can be given IV or oral. The alternative is fomepizole. Fomepizole is a competitive inhibitor of the enzyme. Now, both of these have advantages and disadvantages. Ethanol, unfortunately, sedates the patient, so you usually have to intubate them. You have to check drug levels, and if you're dialyzing, it's a real chore to try to get those levels to be stable. Fomepizole is given as a bolus Q12 hours, so it's easy to administer. It doesn't sedate the patient, so you may avoid intubation, but it costs about $4,700 to treat the patient. However, if you've never seen the running around that goes on in a hospital when you ask for ethanol to be administered IV, this might be a more advantageous treatment as far as getting it started faster. Now, you still need to dialyze because dialysis removes the acid metabolites and it will also remove the alcohol. The indications for dialysis are a level greater than 25, but I can't get a level for a couple of days, so that's really not practical. If you have the right clinical scenario and you have an acidosis, you dialyze the patient. The mortality with these ingestions is about 50%, so you want to get started fast. And this is high flow, high flux dialysis for a prolonged period of time. Other indications, renal failure, visual disturbances, but those are late findings. You'd like to get to the patient before those develop. There's a few other interventions. Thiamine, folate, remember these are often alcoholics. Folinic acid can be used if you know you're dealing with methanol toxicity. It does enhance excretion of the metabolites. Watch the glucose levels, and although in the past we used to give a lot of bicarbonate, the better intervention is to initiate dialysis. Bicarbonate really may help a little bit with excretion, but it really doesn't address the underlying problems, which is getting rid of the metabolites and the alcohol. Okay, you have an intubated alcoholic who required lorazepam infusion for control of withdrawal symptoms. At 24 hours, he's receiving 12 milligrams per hour of lorazepam. On the third day, he was noted to develop an anion gap acidosis and an osmolar gap with a normal lactate. Which one of the following interventions is most appropriate? Stop the lorazepam, start midazolam. Stop lorazepam, start diazepam. Stop lorazepam and start fentanyl, or initiate hemodialysis. We've lost the music. Oh, I'm not going to sing. No, thank you, Henry. You're welcome to come up and sing, though. Okay. The correct answer is A. This is kind of a crossover between alcohol and intoxication. Well, it is an alcohol intoxication. It's propylene glycol. And this is because lorazepam has 830 milligrams per ml of propylene glycol. And it usually occurs with longer-term high-dose use. Usually if it's greater than 0.1 milligram per kilogram per hour, you run this risk. And it is characterized by an anion gap, acidosis, and the osmolar gap, and the osmolar gap seems to correlate the best with toxicity. You actually could get a lactic acidosis as well, although I didn't give it to you in this scenario. One of the difficulties is often one of the signs of toxicity is agitation. So if you're treating someone for withdrawal, you can see the potential cycle you get into. You start increasing the lorazepam. Diazepam cannot be substituted because it also contains propylene glycol as the diluent. But you could use other midazolam. You can't use fentanyl if you're still treating withdrawal symptoms, however. Potentially you could dialyze this off, but most of the time you don't have to do that. You just need to stop the lorazepam in that patient. So, speaking of benzodiazepines, we have quite an epidemic of anxiety in our country, so a lot of people are receiving alprazolam. And what's interesting is it appears to be actually more toxic than our other longer-acting benzodiazepines. More people tend to be intubated, have longer ICU stays than, say, with diazepam or lorazepam overdoses. The antidote is not recommended in the field of toxicology. The reason is, first of all, it's short half-life. If you wake someone up, they're breathing, you walk away, 45 minutes later they're resedated and they may aspirate or become hypoxic. The other problem is that there are contraindications. There's an increased risk of seizures if they're also using cyclic antidepressants. But the real, probably more common reason to be careful is anyone who's using benzodiazepines chronically is at risk for going into withdrawal, which means they're going to seize. And that means you don't have anything to treat them with because you just blocked all their benzodiazepine receptors. Not a pretty situation to be in. So basically, if someone's taking benzodiazepines for more than a week, do not give flumazenil. And I guarantee you, if they're overdosing on them, on a benzodiazepine, they've been taking it for longer. By the way, this is called bars or handlebars on the street. It's one of the very common street drugs. Okay, you have a 25-year-old woman who presented after ingesting some unknown pills. She's lethargic with a pulse of 62 and a blood pressure of 86/40. I'm sorry, there is a rhythm tracing here. Which of the following interventions is likely to be most beneficial in this patient? Transthoracic pacing, atropine and dopamine, glucagon and calcium, or dopamine? Okay, Henry, you don't have to sing. Okay, good. Glucagon and calcium. The bradycardia and the hypotension should make you think of two classes of drugs, beta blockers and calcium channel blockers. Yes, digoxin toxicity could do that, but it's not very common anymore. So think primarily of the beta blockers and calcium channel blockers. The good thing is the treatment approach is very similar if you don't know. Now, if you know you're dealing with a beta blocker, then the first drug to give is glucagon. The hypotension is not due to the bradycardia, but to the negative inotropic effects. So you need an inotrope, and glucagon is an inotropic agent, and it doesn't require beta receptors. Those beta receptors are blocked with a beta blocker. There are anecdotal reports of calcium chloride being effective if glucagon does not work. If you know you're dealing with a calcium channel blocker overdose, then you give calcium, and you may need to use high doses. You may need to use continuous infusion. There are also anecdotal reports of glucagon working if calcium does not work. Ventricular pacing, you might be able to pace them, but it may not raise their blood pressure. And a lot of the drugs we give, everybody usually gets atropine. It just doesn't work for anybody. And again, with beta blockers, these drugs, epinephrine, dopamine, will not work. Now, two other options, if everything else doesn't work, is to consider milrinone, because it's a phosphodiesterase inhibitor, so it can actually increase inotropy, but the trade-off is a decrease in blood pressure. Insulin is being recommended more for calcium channel blockers, particularly using a technique called insulin euglycemia. Insulin is an inotropic agent, but you can tell by the wide range of insulin doses, 0.1 to 10 units per kilo per hour, that we may not know exactly what we're doing, but the main thing is that insulin is an inotropic agent. So if nothing else is working, consider this, and this may soon become more of a first-line intervention than it is currently. Let's talk about cocaine, because that's kind of fun. It's still the #1 drug of abuse in the U.S., and there's lots of toxicities. Cardiovascular, of course, dysrhythmias, sinus tach being the most common. The ventricular dysrhythmias, ventricular fibrillation, and ventricular tachycardia are not that common in the hospital, because they often occur outside the hospital, and they usually don't make it into us. So that's not something we typically see. The most common cardiovascular manifestation is chest pain or acute coronary syndromes. And I'd still like to use this case. It's an old one, but it points out a very important issue. This was a 28-year-old who came in to the ICU with hyperthermia, rhabdo, seizures, and was intubated. And this is his EKG on day 1. It's very typical. It's just a sinus tachycardia. And this is his EKG on day 3. And I think you can see the ST elevation. And actually, there's complete loss of voltage almost throughout the precordial as well as the limb leads. This is a 28-year-old with his MI 3 days after use of cocaine. Now, typically, the chest pain and MIs occur temporally related, usually in a shorter time period, but they have been described as far out as 2 weeks. So your patient may be in the hospital for another reason, but they may be having their coronary event because they were using cocaine. Now, how do you treat these? You give aspirin. Cocaine does increase platelet aggregation, so give aspirin. And then you can choose, if they're having ongoing chest pain, you can give nitroglycerin or benzodiazepines for that problem, but giving both of them doesn't seem to help. Now, these are small studies. I would suggest if they have agitation, give benzodiazepines first. Ventolamine is on the American College of Cardiology guidelines, but really I don't think anybody uses it. And you're probably going to say, you've got beta blockers there, that's not allowed. Well, interestingly, there's been 2 large retrospective series published in the last about a year and a half that show that beta blockers are safe. And in one study, those that got beta blockers actually had better outcomes than those who did not get beta blockers. If you think about this, it makes sense. You're not going to give a beta blocker if someone has got a heart rate of 140, blood pressure is elevated, they have that acute sympathomimetic syndrome. But most of our patients, the drug effects wear off quickly, so if they come in, their heart rate's 80, their blood pressure is normal, and they're having an MI, then give them a beta blocker. You've probably already done that and just didn't know it, so it is reasonable to give a beta blocker if appropriate. Reperfusion is appropriate as well. Many of these people are using cocaine for a long period of time. They're also in their 50s, 60s, and 70s, so they have other reasons to have underlying coronary artery disease as well. Well, the brain suffers, of course, the most common manifestation being seizures, intracranial hemorrhage being much more ominous, and they can look like a hypertensive bleed, such as this one, basal ganglia, and also cerebellar. You can get subarachnoid hemorrhage. This is without contrast. About a third of these people will have some underlying malformation. I think you can see the Berry aneurysm right here. So some of these may be patients who need further intervention to control their bleeding at that time. Now, this was a 35-year-old who came in with a left arm paresis, and he had this hypodense area suggesting an acute stroke, ischemic stroke. They did a big workup for stroke in the young and found that he had occluded his right internal carotid artery. And when someone went back to talk with him about it, they asked him if he was using cocaine. He said yes. They said, well, why didn't you tell us? And he said, you didn't ask me. So please ask your patients. And again, vasoconstriction and increased platelet aggregation probably play a role in the patients who come in with ischemic strokes. Pulmonary complications are not as common anymore, probably because the purity of the drug on the street is fairly high. So we don't tend to see this. This is non-cardiac pulmonary edema. Many of these patients don't need intubation. A few of them may. This resolves on its own within a matter of 24 to 48 hours. This is what a brain looks like at a temperature of 108 degrees after using cocaine. This is kind of mush. There's no sulci, there's no ventricles, there's no gray-white matter. These people do not do well. They get DIC, they get renal failure, they get rhabdo and pulmonary edema, and they tend to die. We haven't seen this in Houston this year because we've had a cool summer so far. One other toxicity I want to point out is agranulocytosis. This is due to the fact that the cocaine in this country, a large percentage of it now is being cut with levamisole, which is an immunosuppressant used in veterinary medicine, used to be used in adults as well. So if you see someone with a low white count that's unexplained, you might go and ask them again about what their drug use might be. Intestinal ischemia and infarction, usually it's small bowel, but it's been described in the colon as well, a colitis. They can have acute pain, it can be chronic pain. They will usually have peritoneal signs when this is occurring. Renal failure, not surprising, rhabdo, and then we mentioned hypothermia already. No antidote, give lots of benzodiazepines for the agitation. Haloperidol is not a first-line drug because it can lower seizure threshold, as does cocaine. So it's really reserved as a kind of a last resort. The main issue with cocaine is to think about the complications and anticipate them and treat them accordingly. Now, very similar to cocaine are the amphetamines and methamphetamines. Of course, this is homegrown type of things, although now the big importation is coming from Mexico. Not all of it is home cooked. The complications are the same as cocaine with one addition, and that's the cardiomyopathy. You see this more with amphetamines because the duration of the physiologic effect with amphetamines is longer. So that sympathetic pounding on the heart lasts for hours instead of 20 minutes or 30 minutes. So these people come in with chronic use and they'll have cardiomyopathies. Now, one other thing to look for in your patients, how many of you have seen this? It's called meth mouth. Yeah, pretty nasty looking stuff. So if you see these kind of really bad dental hygiene, go back and ask them about methamphetamine. This website I have there for you if you want to know anything about current drug use. This site links to the medical literature, but it also has personal experiences of people. They took the recipes off now, but it has a glossary of terms, and it really is up to date. I always tell people don't do this at work because they may track where you're going on your computer and ask questions. But it is very helpful when you're looking for some of these things. Amphetamines, methamphetamines, by the time they get to us, they're absorbed. So all you can really do is anticipate the complications and use lots of benzodiazepines, again, for the agitation. Well, I thought this would be fun anyway. Propofol abuse. It turns out it wasn't just Michael Jackson using this. It turns out that there's quite a few cases of propofol abuse going on, and it's being administered for chronic headache, euphoria, sleep, stress relief, and it is used occasionally for suicide and homicide. Now, are there anesthesiologists in the room? Okay, I just have an important fact for you. 18% of you were probably abusing propofol in your anesthesia training programs. This is an interesting fact that I didn't realize this. I knew about narcotic abuse, but so far it's only been described in anesthesia. So it's not as uncommon as you might think to see propofol abuse. Okay, here you have a 30-year-old with a history of depression who presents with altered mental status and the EKG. Actually, there's quite a few little rhythm strips here. So looking at that EKG, which one of the following interventions is indicated for the arrhythmia? Amiodarone, cardioversion, magnesium sulfate, or sodium bicarbonate? Okay, good. Now, the main thing on this rhythm is just that it's wide, complex, and it's a tachycardia. And the clinical history, a 30-year-old with a history of depression. This would be an antidepressant till proven otherwise. So the intervention here that you want to use is sodium bicarbonate. Now, often we talk about this with cyclic antidepressants, but in reality, all of the antidepressants, even the newer ones, can give you arrhythmias, wide, complex tachycardias. And the treatment is still the same. Bicarbonate for significant cardiac toxicity. I think also in your slides, and you can't really see it up here, one of the things I just want to point out, Brugada syndrome, the Brugada changes on EKGs have also been described, and sometimes they're mistaken for ST elevation. The more common manifestation of antidepressant overdose is actually a depressed level of consciousness. Seizures and hypotension, much less common. Now, this is a life-threatening ingestion, so you have to monitor, of course, their airway, their cardiac status. If it's early, you can give charcoal. If it's really, really early, you might consider lavage, but again, please don't feel like you have to do that. Now, we alkalinize the blood for significant cardiac toxicity, and there's a slide in your handouts that gives some of the criteria that have been proposed, and you can see they're variable. But probably instead of saying blood alkalinization, what we should be saying is sodium loading. These drugs block the sodium-potassium pumps in the myocardium, and so when we give sodium bicarb, we're giving sodium, which helps overcome that blockade. And that's one of the reasons that if you have someone who's refractory to regular doses of sodium bicarb, try hypertonic saline. 3%, some of the studies that have been done suggest 7%, but I think in the U.S. we primarily will be using 3%. Other antiarrhythmic drugs, if it looks like Torsade, you use magnesium. Vasopressors, you want a direct alpha agonist if your hypotension is refractory to fluids, and of course benzodiazepines for drug-induced seizures. And I put oral hypoglycemic agents up here because we have so many people that are diabetic now and on oral agents. We are getting quite a few of these patients in the ICU. Now, our traditional treatment is to give concentrated glucose like D50 or start 10% dextrose or 20% dextrose. You could also give glucagon, which releases glycogen stores from the liver. The problem with both glucose and glucagon is that both of those increase insulin secretion from the pancreas. These oral agents, sulfonylureas primarily, also do the same thing. So we're kind of, again, starting a vicious cycle. Keep in mind that one of the options you have, and I would encourage you to try this because if you haven't, it actually does work, is octreotide. It decreases insulin secretion from the pancreas. The dose is 50 to 100 micrograms every 8 hours. You can give it sub-Q or IV. What it does is it shortens the hypoglycemic period. You don't have to give as much concentrated glucose, and it really does smooth out the management of these patients. So that potentially could be something that might show up on the board. Narcotics, tenfold increase in the abuse of narcotics, opioids, in the last 15 years. So opioid use is going up. And this is not, as you notice, this is heroin down here. It's our oral opioids. How many of you have ever heard of purple drank? Okay. It's also called Houston drank. How many of you have heard of the trio? Okay. Houston trio, no, not the Kingston trio, no. No, the trio. They might, no. Okay. Narcotics are a big problem. Purple drank is codeine cough syrup, codeine plus promethazine. Johnny Jolly was suspended from the Green Bay Packers. He's a Houston native, and several other football players for this. There's actually some kind of soda water or something called drank now. It's meant to be mixed with this syrup. The trio is alprazolam, Vicodin, it's Xanax, Vicodin, and Soma. That's called the trio. In Texas, we've had in Harris County alone, we've had almost 250 deaths in 2009 due to prescription drug abuse. In Harris County, we write 40% of the prescriptions that are written in Texas for all the trio drugs. This is the pill mills that are being churned out, and this has been spurred by the emphasis on pain control. Smiley faces for everyone, okay? Well, unfortunately, and we overdose our patients in the hospital occasionally. We do have an antidote, which is naloxone. The problem is with the synthetic narcotics, you're going to need to use higher doses. We have hydromorphone in our hospital, and we get maybe 1 or 2 a month that kind of go to sleep on the floor and end up in our unit because of hydromorphone. Codeine is another one, but methadone is another street drug that is out there as well as for legitimate use. It's used a lot in the pain management, so it's longer acting. Keep in mind that fentanyl is also abused. It is not detected on screens as a narcotic. And fentanyl, this is some of the Vicodin, but fentanyl is available as lollipops, of course, for the cancer patients as well as patches. What they do with the patches is they actually squeeze the liquid out. Sometimes they heat it and inhale. This is extremely potent, and these people will often die very quickly. Again, if someone responds to naloxone and wakes up and their drug screen is negative, they have narcotics on board. Drug screens are not 100% accurate in these populations. Cholinergic syndromes, these are the hypersecretory states: salivation, lacrimation, urination, defecation, GI upset, and emesis, the sludge syndrome. We typically think of these with insecticides, organophosphates. It's not common in the U.S. because we don't use much of organophosphates. It's more common in developing countries. We have carbamates, which are much less toxic. But the board question might be about a nerve gas. And it's been long enough after 9/11 to where this could appear. Sarin gives you a cholinergic syndrome. These people die of asphyxia from the respiratory secretions. So the treatment of choice initially is to give atropine, and more atropine. The dosing is there on a couple extra slides in your set. Pralidoxime is used to reverse the muscle weakness. So you still have to get it in early, but not immediately. Intubation does not save these patients because the secretions are below the endotracheal tube. So it's a lot of atropine that may be needed. The bradycardia is described, but in reality, a lot of these patients will actually have a tachycardia on presentation. I want to mention salicylate simply because it's not real common, but again, it's shown up on board exams in the past. The problem here is those who chronically ingest, which tend to be our older patients. And you ask them if they take aspirin, they say no, because they take Goody's powders or BC powders, which have salicylates. Chronic ingesters are more likely to get into trouble than someone who takes a single acute overdose. Some of the manifestations, if you look at them, altered mental status, fever, respiratory alkalosis, metabolic acidosis. This looks a lot like sepsis. In fact, this has been called pseudosepsis syndrome. So keep this in mind if they give you a scenario like this. And if you have an older patient presenting like this, think about salicylates. The management is hydration. They're all dehydrated. You alkalinize the urine to enhance excretion if the level is greater than 30. If you alkalinize, remember you're going to have to replace potassium. Treatment, as far as dialysis, is really reserved for severe manifestations. We don't typically use a level anymore, but those who have refractory acidosis, profound depressed level of consciousness, or who have refractory seizures, those who are candidates for dialysis. Okay, you have an ICU patient who overdosed on a monoamine oxidase inhibitor and fluoxetine or Prozac. The patient is delirious, has had several seizures, and has tremors of the extremities. Which one of the following should be administered? Dantrolene, lorazepam, propranolol, or bromocriptine? Okay, well, the correct answer is actually B. This is a serotonin syndrome. This is not neuroleptic malignant syndrome or malignant hyperthermia, so dantrolene would not work. The key is looking at the drugs. Here's your serotonin syndrome, SSRI drug, and you can put that in combination with many other drugs, monoamine oxidase inhibitors, another SSRI, combination with lithium, combination with narcotics. This can cause serotonin syndrome, and it looks a lot like neuroleptic malignant syndrome, but it's a different mechanism. This is due to serotonin excess in the brain. Now, often you can also see arrhythmias, just depressed level of consciousness, but the unique feature is the serotonin syndrome, which the triad here is the altered mental status, the autonomic dysfunction, and the neuromuscular abnormalities, which can be some rigidity, it can be this shaking or tremors or just a jerking of the extremities. The treatment of choice here, don't forget about linezolid and tramadol. Linezolid and tramadol both can precipitate serotonin syndrome, and that would probably be the question I'd ask you, is give you some combination with linezolid and tramadol in your patient. So, and we use a lot of linezolid today, so it actually is a real concern in your patients. But stop the agent. It's supportive care. You have to manage the airway. You have to manage their blood pressure and their cardiac status. It would be extremely rare to need neuromuscular blockade in these individuals. Some have proposed serotonin antagonists, specifically cyproheptadine. Most of the recommendations come from a few case series, but again, you might consider that. But these people get better in a matter of 24 to 72 hours. I want to mention valproic acid toxicity because we see this drug being used more not only for seizures, but also as a mood stabilizer. And if you ever have anybody with coma of unknown origin, check the valproate level in these people. You might be surprised, but they really can have a profound CNS depression. They can get hypotensive, they get hypernatremic. Hyperammonemia is also a hallmark, and this ammonia is not generated from hepatic dysfunction, it's a mitochondrial generated ammonia. Now, the treatment, of course, is to stop the drug. These are long-acting and often sustained-release drugs, so you have to monitor the levels over time. It's been proposed that if they're altered, check an ammonia level. I'm not real sure what I'm going to do with the ammonia level. There are some who have proposed using L-carnitine based on the pediatric inborn errors of metabolism, but there's no good evidence that it is beneficial. That does make them smell kind of fishy, but it really may not help them. More and more, though, if you have a patient who's hemodynamically unstable, go for hemoperfusion or hemodialysis early. We actually lost a young man to overdose with valproate last year. So I think I'm convinced enough that if they're unstable hemodynamically, go ahead and dialyze or hemoperfuse them. Quick word about the herbal products, because these are always fun. Ephedra was banned back in 2004, but then a year later the FDA reversed that, and they're now allowing low doses. Ephedra is a sympathomimetic, just like cocaine. You can get MIs, you can get rhabdo, you can get seizures, you can get dead as well. Now, in that year's time, there was a lot of entrepreneurial spirit in this country, of course, and then we had ephedra-free supplements. And if you look at the contents of these, they contain bitter orange, which is actually synephrine, and also octopamine, and those sound a lot like our catecholamines, and they are. So now there's reports of MI, stroke, syncope in these patients as well. And Xenadrine seems to be one of the brands that has more of these effects than some of the others. Now, the newer ones on the block are the caffeine and the energy drinks. How many had one today? No? Okay. Besides the regular coffee. Okay. Well, this is actually becoming a real problem because the younger adults are drinking 4, 5, 6 cans of this a day. And now we're seeing reports of arrhythmias, particularly we get atrial fibrillation and also cardiac arrest. So be careful about how many you drink trying to stay awake during this course. 2 websites that are listed for you, herbmed.org, and also this one is from Memorial Sloan Kettering Cancer Center. They have a large complementary medicine section, and those websites are actually very valuable if you want to look up some of these herbal supplements. Just lastly, I wanted to mention hospital-acquired overdoses because, they're not going to pay us for anything that's hospital-acquired in the near future. And there are things that happen in the hospital that we potentially could avoid. Gabapentin overdoses, this happens when you don't adjust the dose for renal failure, and these people will go to sleep. And it takes a while for them to wake up. Long-acting insulins, particularly with renal insufficiency. Again, in our zeal to control glucose levels everywhere in the hospital, we're seeing more hypoglycemia. We've already mentioned propylene glycol, that's hospital-acquired. Propofol infusion syndrome, another hospital-acquired intoxication. And this morning we mentioned methemoglobin coming from the topical anesthetics. So just a couple of words about propofol infusion because this might be on board exams. It's called the PRIS syndrome, I guess because if you took the R out, it wouldn't sound very good. But the high-risk patients are the sepsis patients, those who have impaired oxygen delivery, that's all of our critically ill, head injury. Typically, it's in patients who have prolonged infusions at high doses. However, this has now been described in patients, particularly surgical patients, receiving lower doses over shorter periods of time. And the manifestations, again, can be difficult to pick up in a critically ill patient. They get arrhythmias, they get lactic acidosis. This is not due to hypoperfusion. This is mitochondrial abnormalities. They get acute renal failure, and the mortality rate is actually, from what we know, very high if you don't pick this up and stop the propofol. Now, I don't know about you, but in the last week we've been told no more propofol because there's a severe shortage. So they're preserving it for the OR. So this is probably a good thing. If you're using a lot of it, it's a good time to cut back. So I'll stop there. Thank you very much for your attention.